and injecting drugs for macular degeneration. But it bothered me tremendously when I saw a patient I could not help. And I did not accept the fact that I would tell that person, well, there's no treatment. And they would always respond to me by saying, well, are they working on something? Well, who is they? They is us. They is me. They is you. There is no collective they out there working. It's us. And I recall reading about the first time penicillin was used to save a life. It was considered a miracle. Now we take it for granted. You have to start somewhere. So I am treating the untreatable. I am treating people who have never had hope, who were told by their physicians, there is no treatment, go away. Most physicians are quite nice about it. Some are downright mean. Save your money and buy a guide dog, I've heard. Patients have told me. Some physicians have told their patients, oh, there's nothing to help you. There is nothing at all, go home, and that's it. When they should say, I'm not aware of something that might help you, which would be more accurate. Because when a physician tells a patient there's no hope and go home, you have consigned that patient to blindness, which is a terrible, terrible thing. And I assure you, because I've seen it, if it was that physician's family, he would find me. He would not accept that, oh, that's it, you're blind and go home. So ethically, when a physician gives advice, he needs to be aware of what's going on. Now, admittedly, I've given 7 talks here. I don't expect every physician to be here. Certainly if you know the country, you're not going to be here. I don't accept or expect every physician to have read the 2 papers that I publish in peer-reviewed journals. I don't expect physicians to know the other 3 papers I've submitted for publication. I don't expect a physician to have seen this on television in the US, or read the newspapers in the US, or gone online and read patient blogs where they speak about their experience. But I do expect them to look at clinicaltrials.gov, which is the National Institutes of Health website, from which I get probably 95% of the patients from all over the world coming to my office in Florida and now here in Dubai for treatment. Because the patient's family looks. And the NIH website lists all the registered clinical studies in the world on every condition. And if you go to that website, and all you have to do is type in eye stem cells. My study is ranked #1 in the world. And it discusses the protocol, and what exactly we're doing, and the indications, and everything is there. So I do expect a physician, before giving fatal advice to a patient who is losing their vision or has lost their vision, to at least try to look for something. Because a doctor can close his eyes very tightly and say there's no sun in the sky. But then who's the idiot? So, having given my lecture, I'll now start with the second part of the lecture. This is called bone marrow fraction, which really is a euphemistic expression for stem cells. It happens that the majority of what I'm injecting are not stem cells, probably 90% are. It's really platelet-rich plasma, which I'm calling bone marrow fraction. This is an autologous concentration of human platelets in a small volume of plasma. The normal platelet count averages approximately 200,000 per microliter. This is 1 million per microliter. But it's normal. It's not expanded. There's nothing unnatural about it. It's from the patient. It contains 3 isomers of platelet-derived growth factor, 2 of transforming growth factor, vascular endothelial growth factor, epithelial growth factor, cell adhesion proteins, 7 native growth factors within a normal clot as a carrier. Again, it's not processed, it's normal. Uses, well, nerve injury. Nerve regeneration includes the regrowth of axons, myelination, and synapses. PRP contains growth factors that promote healing. They're released from platelet alpha granules, and motor nerve recovery and stroke recovery has improved with PRP. The growth factors are the key. Platelet-derived growth factor, fibroblast growth factors, insulin-like growth factors, vascular endothelial growth factors, epidermal growth factor, connective tissue growth factor. This is a 54-year-old female. Her right eye suddenly lost the vision upon awakening in June 2010. The right vision became 2400. There was a superior altitude visual field defect. The left was 2030. There was a supratemporal and infranasal visual field defect. 4 months later, she lost the infranasal visual field in the right eye. A couple of months later, she lost the infratemporal visual field in the right eye. And then the left eye was attacked. It was 2070, deeper defects than previously. So she had multiple attacks in each eye. The records were reviewed. There was no proptosis, no motility, abnormality, no retinopathy. The visual field in the right eye was almost 0. Left, there was supratemporal and infranasal loss. The OCT, ocular coherence tomography, which measures the thickness of the retina, was reduced. And then a workup began. Now, one thing I have noticed is I've seen patients here with optic nerve injury, and many of the patients were told that the doctor doesn't know what happened. Well, not knowing, I mean, physicians use a nice word, idiopathic, or unknown etiology, but everything has an etiology. You just really have to look. And obviously, when you treat somebody, it helps to know what the particular problem is. It'd be like if I tell you the brakes on my car don't work, you fix the brakes. If I tell you the car's broken, then you don't know. You have to look everywhere. So blood work for autoimmune disorders were ordered. The tests are listed down below there. And what was found, that she was positive for an anti-optic nerve autoantibody against a particular protein. This is very expensive workup, but at least now we know why this is happening. The top visual fields are the preoperative. Left eye was 2070 with field loss up here. And the right is counting fingers. Unable to drive, she lost her job, 54 years old. Single mother of 2. This is 3 months postoperatively. The left eye improved to 2015 vision. The right eye improved to 2200. This is darker here because it's a new ink cartridge, but you see there are windows of sight here. And so she improved from counting fingers to 2200. And she got her job back. So she has a life again. This is the second patient, only 23. She works in a hair salon, cleans up many chemicals. January 2013, sudden hand and arm numbness, flushing, numbness around mouth while driving. February, March, new headaches, opening pressure was high, was placed on Diamox. April to June, she lost essential vision to bare light perception. Light perception means that you can only tell there's a bare light perception, there's a light. You cannot see a finger this close to your eye. You cannot tell a hand is moving. Bare light perception is right before no light perception, which means complete blindness. So here was a 23-year-old woman who went almost blind in each eye. She underwent bilateral optic nerve sheath decompression to hopefully regain perfect vision. Didn't work. Her blood test for Leber's was positive. So this is Leber's hereditary optic neuropathy. So now we have a cause. Now, the study that I'm doing in the U.S. has 3 arms to it. And what the arms mean is 3 treatment pathways. Arm 1 means I inject the stem cells just around the eye. Arm 2 is around the eye and intravitreally inside the eye. And arm 3 is I go inside the eye, I do a vitrectomy, and for a retinal condition, I inject the cells directly under the macula using a needle I invented, or inject directly into the optic nerve in an optic nerve condition. So that's what I did here. And these are stem cells. Stem cells are red, so this is not blood. And here are the stem cells. And this is 1 month post-vitrectomy. And there's no leakage here, so there's no damage. But the field's improved. This was preoperatively. She was hand motion. She went to 2800. And she could see more. And this I went to counting fingers. But the difference between this, you cannot ambulate with hand motion. You need to be led around. Here, you can walk on your own. So at 23 years old, she can walk on her own. And that matters. And the thickness of the retina also improved, which again, we were all taught is impossible. But the impossible stays impossible until it becomes possible. That's all. This is a 27-year-old female, and this is an interesting case because at the end, about 3 weeks ago, ABC News in the U.S. came and did a story on her, and I'll show you the TV clip at the end. This girl wanted to be a policewoman, and then in 2009, she started losing her vision. She was followed at the Wilmer Institute of Johns Hopkins University, very, very prestigious, top place. And I'll let you hear directly from her about what happened there. She was diagnosed with idiopathic optic neuritis, optic atrophy, which means it's a nice word that they didn't know. She was 5/400 vision in one eye, 5/700, and then just kept getting worse. In 2014, when I saw her, she was 5/200 in the right eye and 1/200 in the left eye, which essentially she could count the fingers in front of the right eye at about 5 feet away and the left eye at 1 foot away. Now, in the arm 3 procedure, I do the vitrectomy in the worst eye. So I did the vitrectomy in the 1/200 eye, which meant she could see a finger this close, and that was it. 3 months later, the eye went from 1/200 to 20/40 minus 2, which is incredible. And in fact, I will share this with you. She went back to Hopkins, who was totally against doing this, saying there's no proof, and we don't know about it, and we never heard of this, and they shouldn't do it. And she said, I'm doing it, I have nothing to lose, I'm blind. So when she returned there for follow-up after the surgery and said that she had the procedure, the doctor started yelling at her, saying that you were ridiculous, that everybody in Florida are thieves, and they don't wear shoes, and they're crazy, and everything else. And then he checked her vision, and she read the chart, and his jaw dropped. And 6 months later, Hopkins called her to give a talk for them to raise money. And she called me up, and I can't repeat what she said about them because they were not nice words. A lot of them were 4-letter words, but she thought they had incredible nerve when they didn't help her. In fact, made her cry to ask that she should raise money for them. At Wilmer Eye Institute, she was then 2100 plus 1 in the right. That improved to 2040 minus 2 in the left eye. The visual field improved as well. She's now 2040 in the right eye and 2025 in the left eye. She got married. She wrote me a beautiful letter saying that she saw her fiance's eyes for the first time. I mean, really, I could cry reading these things. And she opened a restaurant. So she has a life again. And when ABC News came to my office in Florida, she flew down wanting to be interviewed, and I offered to pay for her airfare and a hotel, and she refused to accept money, saying, "You gave me my life. Wherever you need me to go to talk, I am happy to do so, because I have a life now, and I never had it before." Now let's talk about non-arteritic anterior ischemic optic neuropathy. What you know about this condition is there's no treatment, and that's wrong. And now you're going to see why it's wrong. It's ischemic, it's non-inflammatory. In the US, the prevalence is 2.3 to 10.2 per 100,000 population. Mean age of occurrence 57 to 65 years of age. Painless loss of vision, hours to days. There is a progressive form, 22 to 37% of cases. Most cases are idiopathic, which, again, that nice word. But we do know that radiation can cause it, hypotension can cause it. 55 to 80% are altitudinal, generally inferior visual field loss. Vision is generally stable 2 months after the incident. And that's important, and I'll show you why. 52% of the patients, the acuity is 2200 or worse at 6 months. So legally blind. Second eye involvement, 14.7% median of 5 years. Risk factor for the second eye involvement is visual acuity of 2200 or worse in the first, and diabetes, which is very prevalent here. Well, causes. I mean, obviously it has a cause. Some people have been indicated it could be thrombosis. I think that makes tremendous sense, because certainly if you're hypotensive and you're sleeping, and frequently the people notice it when they awake. We know hypertension alone can cause that. And then as a result of the axonal swelling, you get a compartment syndrome, and then even if the clot passes or is not identifiable on pathology, which seldom happens because the patients don't die, they just lose their vision, you won't see a clot. And we speak about the crowded optic nerve or the disc at risk. It does not have a cup, or it can be compromised, again, thrombosis of the posterior ciliary circulation. Interestingly, you can get inner retinal layer atrophy, but you have preservation of the retinal nerve fiber layer and the ganglion cell layer, even in NLP and no light perception eyes, which indicated to me that there might be a potential for recovery. You cannot equate disc pallor with visual function, which people do. And the treatments that have been tried include anticoagulants, dilantin, atropine, steroids, vasodilators, optic nerve sheath depression. Obviously, any condition that has many, many treatments doesn't have one that works. That's why there are so many. So, 13 patients that I've done, 57 to 88 years of age, 12 males, 1 female. The history of 1 to 35 years with this condition. So clearly, there is no chance of improvement according to all the natural history studies, which we said normally 2 months, 6 months, it's stable, that's it. It's not going to change. So this is 1 to 35 years. 11 out of 13 eyes improved. Now, one thing I wish to note is I see the patients at the time of surgery. The pre-op and post-op follow-up are done by physicians I do not know. So clearly, there's no ability for me to fudge data. If anybody ever says that, it's completely untrue. It's not possible. That patient went back to Johns Hopkins, an institution that was completely against this. These patients were followed at the University of Ohio by a neuro-ophthalmologist who I never met. And in fact, this is one of the papers that has been submitted for publication. So of the 11 eyes that improved, 2 eyes were 1 to 3 letters better, 1 eye 4 to 9 letters better, 3 eyes 10 to 20 letters, 5 eyes 21 to 42 letters better. This is huge improvement. We had 2 eyes that got worse, 1 minus 4, 1 minus 10. That patient had developed a cataract, which can be fixed. Now looking at the moderate and significant improvement, 10 to 42 letter improvement, 3 eyes were arm 3 and 5 eyes were arm 2. Because I'm asked, well, which one does better, arm 2 or arm 3? Well, that's the problem. Some arm 2, some arm 3, which is why in these cases I do a vitrectomy in arm 3 in one eye and the arm 2 in the other eye, so each eye is not in the same basket. And all these eyes had improvement in visual fields, and they remained stable in their improvement, 9 to 12 months. These are some references. And now I'd like to show you this video.
We have an eye-opening podcast for you today. South Florida retina surgery is breaking new ground in the fight against vision loss. As our medical specialist, Christy Kruger, shows us, the doctor is using patients' own stem cells to help them see again. He is the only one in the country performing this procedure.
Being able to read a magazine is a small miracle for Vanna Belton. 6 years ago, the 29-year-old from Baltimore suddenly began to lose her vision. Doctors said her optic nerve was inflamed, that the condition was temporary.
Within a month, both my eyes were beyond legally blind. And they just kept telling me every check-in, it's fine, it hasn't been a year. And when 8 months came, they said, this is permanent. We don't know what you have.
After years searching for help, Vanna found South Florida Dr. Weiss, who's using stem cells to restore sight.
Well, approximately 60% of the people on treatment are getting some improvement. We've had about 8 people not get driver's licenses.
When Vanna first met Dr. Weiss, the most she could see was a finger right in front of her face. But that all changed when she became part of a breakthrough study at the Park Creek Surgery Center.
Every almost week and month, it got better and better. It took me, before I could read a part of a letter. And now I read magazines in waiting rooms. I read my iPhone.
First, bone marrow is extracted. Then stem cells are separated out in this machine and injected around or within the patient's eye.
You have dead cells, and then you have cells that are just idle. They're not dead, they're not functioning. And we may be kickstarting them by giving these growth chemicals and these growth factors.
Vanna can see so much more than just that one finger right in front of her face now, but she's not done yet. In fact, she's coming back in February for another procedure with the hopes of one day being able to drive again. Recently, Vanna got married and opened a restaurant and says today she really does see a bright future.
It was fantastic to find something that wasn't a treatment or a pill, but it's a cure. And that to me means so much more, to use my own body to heal itself.
And Dr. Weiss has treated about 250 patients from around the world in the stem cell ophthalmology treatment study. Patients who qualify for this have vision loss because of retinal or optic nerve conditions. So for more information, go to our health section of Local10.com. In the newsroom with your HealthCast, I'm Christy Kruger, Local 10 News.
She's coming back next month to have it a second time. See if she gets more improvement. Any questions? Yes, sir.
Thank you very much, and great work.
Thank you.
So in order we recommend this treatment to our patients, they would be asking us some questions as an eye doctor. When they come for treatment, does the patient need to come for multiple sessions, like each eye needs bone marrow fraction to be taken for each treatment, or can you preserve it? Can you keep the stem cells for a second treatment?
No, this study is institutional review board approved and FDA compliant. And according to FDA guidelines, everything has to be in the same surgical procedure. The procedure is normally records are emailed to me, and I review them to see if the person's eligible or not. If they are eligible and they consent to come, I examine them on Monday to confirm the diagnosis. They come to the operating room on Tuesday. We have 3 teams in the OR. First, they're placed under anesthetic, so they don't feel anything. An orthopedic surgeon.
Is it local or general?
This is a general, but it can be done in the local. It's patient preference. Most people do general. It's short-acting, LMA, not endotracheal tube. Under anesthesia, an orthopedic surgeon, here an interventional radiologist, does a bone marrow aspiration. Those cells, the bone marrow aspirate, is placed in that FDA-approved machine. And according to the protocol that I've developed over the last 4 years, we minimize the amount of red cells and maximize the amount of nucleated cells. And those cells are provided to me. While that's being done, I'm doing the vitrectomy. So everything is happening simultaneously. This entire procedure takes less than 1 hour because there are 3 teams working essentially simultaneously. There's very little discomfort. If they have a vitrectomy, I take the patch off the next day. If they're in arm 1 or arm 2, there's no patch. I see them on Wednesday, and if they're local, that's it. I see them back in a month. And if they're coming from out of state or out of the country, they fly home on the Friday.
So if you need to treat the other eye, can you use the same, you have to go through the same process again?
No, both eyes are treated at that sitting. Both eyes are always treated at that sitting if both eyes need the treatment.
So you do bilateral, you do one vitrectomy, you don't do bilateral.
No, arm 3 is only 1 eye and always the worst eye. Here at Zahra Hospital, I'm only doing arm 2 because the vitrectomy situation is now that has gotten set up, and maybe in the future I'll be doing them arm 3. But most of the cases are really back home as well, arm 2, where I do an intravitreal injection, subtenon's injection, and retrobulbar injection of each eye, and the remaining cells are reintroduced intravenously. And that's it. Now, that's the entire procedure. Patients have come to me who got improvement, like Vanna, and said, you know, I got improvement, can I have it again? I tell them to wait a year. And she's now coming back in February to have it a second time. We do the same procedure. The second time, I don't do the vitrectomy. I do the vitrectomy 1 time. Just do arm 2. Because she's 20/40, 20/25. I mean, that's like you won the lottery, and now you'd like to try to win a second time. So with arm 2, the chance of infection is 0.0004, which is negligible. And we've had no complications from that.
So arm 2 is an intravitreal injection without vitrectomy?
Correct. Arm 2 is intravitreal. Arm 1 is just around the eye. Arm 2 is around the eye and an intravitreal injection. Arm 3 is a vitrectomy and injection into the optic nerve or subretinal and subtenon's injection. And then whatever cells are left over, we return to the patient intravenously.
So there's no material that you can keep for a second
No.
treatment?
No, well, it would be a year, no. We'd have to preserve that. And quite frankly, the bone marrow aspiration is the easiest part. It's a 5-minute procedure. It's nothing. And then we separate it out according to protocol. That needs to be used because unless you freeze it, and most of the patients, quite frankly, they don't come back. They are happy with their improvement. It's the exceptional patient that says, hey, I'd like to try again and see if I can get more. That tends to be the younger people. The older people tend not to do that again.
I have After my question,
Well, you can, patients look up to them, and if the physician says, there's nothing, that's it, they go home. And they sit there and let their lives pass them by. And that's a sin. I frequently use the example, if you see a stranger walking towards an empty elevator shaft, you would yell at them, even though you don't know them. And the patient, they may look at you and think you're crazy yelling at them. They don't know you. And if that person walks into the empty elevator shaft and gets killed, you don't know that person, but you feel bad, don't you? You feel terrible. Well, that's how I feel when I see a patient come to me here, as happened yesterday, and is trying to decide, and they're going blind from retinitis pigmentosa, and the family's telling me they can't see their food, they can't see this, and they just can look down these tubes. That's all they have left. But their at-home doctor said he doesn't believe in any of this. Well, did he call me? Did he ask me? Is he here? No. So the patient doesn't know what to do because the doctor they've known for years says this is nothing. And I'm a stranger who just happened to get off a plane. And now they decided not to have the surgery. And went home. And they're probably going to go blind. And that's, to me, like the stranger walking into the empty elevator shaft.
happens a lot.
It happens a lot, and it shouldn't, because to me, it's unethical. If you are a physician and you took an oath, you shouldn't act that way. But physicians are people. There's all kinds of people. There's nice people, there's bad people, there's good people. Intelligent people, ignorant people. Any other questions? Yes, sir?
Thank you very much. This one mode of action treatment mechanism and hyperbaric oxygen treatment are both are same or different? Hyperbaric oxygen.
You attended my prior
Yeah.
talk. Thank you. I recognize a fan. Actually, we know that hyperbaric mobilizes stem cells. So as a result of all this, I also have a hyperbaric center in the US, and I gave that talk. And so after the procedure, if the patient is local, or if they're going to stay a little bit, I do hyperbaric treatments to mobilize more stem cells.
How do you do that?
They just go into the chamber. 1.5 atmosphere, it's very easy. I've had them. It actually, people use it for wellness. It's been around 150 years. Most physicians are not familiar with it because we're not taught. And so it's a little niche. But having been in the chamber myself, so I can answer patient questions, you feel better. It's relaxing. It's supposed to increase your IQ. Maybe it did. It turns gray hair brown, which it does. But you still have to have hair. Unfortunately, it doesn't allow you to grow hair, which is a downside. But I've combined one with the other. Again, if you don't try, you get nothing. And you have to try. And it's not like I'm sprinkling magic dust on people. The science is there. But most people, if you're an ophthalmologist, they just read ophthalmology. You're an OBGYN, you just read OBGYN. But at the end of our name, it says MD. So you can, I'm running out of time. I was just told from the back. Okay, we'll finish up. It says MD. And knowledge is knowledge. Nobody's pigeonholed. So the hyperbaric literature, there's a lot of things there. And this article is from the University of Pennsylvania, a recognized institution, that proved that hyperbaric mobilizes stem cells. So I said, well, let's combine it with this. So there's no dancing with maracas. This is all hard science. Everything I have shown you and told you about, I have proof behind it. Any other questions? Thank you very much.
Procedure can be used in peripheral circulatory failure, in microangiopathies.
Well, I have not done that. People are looking at doing this for peripheral ischemia. Hyperbaric certainly can be. And that would be very interesting to do. If you had hyperbaric here, that would be a fascinating project to combine the hyperbaric with the IV infusion of the stem cells, which would be very easy to do. And again, it would be unique. Nobody's doing this. The hyperbaric people are here, the stem cell people are there. I mean, nobody speaks to one another. But that's what's so good about this forum. This is a very good idea, because people can be helped. And that's why we're all here. That's why we became physicians, to help. So does it matter that whether you take the help from over there and bring it here? Shouldn't. Anything else? Thank you very much.
Is there a join us for dinner?
Sure.